Ladies and gentlemen, we move on to the second presentation on hypertrophic cardiomyopathy, when to intervene. I'd like to invite Dr. R.N.Seth. He is an associate professor of medicine at the Drexel University and Hahnemann Medical College from Philadelphia for the next 11 minutes. Doctor.
Good afternoon, chairpersons, a small but august audience. I'm going to present to you the hypertrophic cardiomyopathy and when to intervene. And the very beginning I must start with, we have come a long way, baby, as they say it. And why am I saying it? These two slides will prove in the first place. The new paradigm is contemporary treatable disease compatible with low mortality and extended or normal longevity. Treatment interventions change clinical course of disease. That's what we believe now in 2015. Yesterday we talked about Eugene Braunwald, and I mentioned his name again in the closing moments. And this article is from the year 1962. So that's about just 38 years there and 15 years there. So we're talking about 55 years or so. At this time, we are aware of no method of management that can specifically and favorably influence the course of a patient with idiopathic ventricular hypertrophy. So you can see how pessimistic were we then and how optimistic we are now. Having said that, I think I'll make my presentation very short and sweet so that you cannot say that I belabored more, because three speakers have so far, including about 4 speakers away from Chennai, already mentioned most of my talk, so I don't have to repeat it. The definition that I give to this hypertrophic cardiomyopathy is unexplained. Unexplained, no cardiac or systemic disease, accompanied by electrical instability, sudden cardiac death, even in asymptomatic patient, autosomal dominant inheritance, and germline mutations. Enough talked about it by previous speakers. Clinical presentation, I define in simple terms, SAD. S stands for syncope, unexplained, A, angina or chest pain, and D is dyspnea, which is congestive heart failure, or various modifications of that. Variable EKG findings, again I described mainly in 3 parameters, one being left ventricular hypertrophy with repolarization abnormalities, B, the inferior wall or infralateral myocardial infarction pattern, pseudo pattern, and C, ventricular fibrillation or torsade. Other modifications are also there. I will not go into detail because it's a late hour. The echocardiographic abnormalities are many, and I'll mention a few, if I may, later on. Various treatment modalities mentioned later on. The most common genetic cardiovascular disorder I'm talking about. Most common cause of sudden cardiac death in young. And sudden cardiac death may be the first and the last symptom. When I said the very first slide that I showed you, this slide only substantiates that statement. Survival to advanced age in hypertrophic cardiomyopathy, here onwards I'll call HCM, in most patients do require much or no treatment at all. And yet you see 19% survival at age 70, and 2% have lived up to age 90 years of age. So it's a pretty good survival with or without any treatment. Sudden death in young athletes, you can see the first or the last symptom I was talking about, 36 to 39% is the cause of sudden death in young athletes. The second being the coronary artery anomalies, 13 to 17%, and all others, which being not Brugada, because that's old age disease, Noonan's, or Romano-Ward syndrome, or long QT syndrome, whatever you want to call it, they are all very few and infrequent, 2 to 5%. So we have to focus ourselves on the sudden cardiac death in hypertrophic cardiomyopathy. And here you see a pyramid here, the lowest incidence sudden cardiac death and the highest incidence sudden cardiac death, which has been hitherto prevented by advances in ICD, because it's electrical death as you see it. Those patients who are prone to primary or secondary death are patients with the more than 10 to 15% of LGE, which is late gadolinium enhancement test, which is a MRI test, LGE more than 15%, or cardiac hypertrophy of more than 30 millimeters in the posterior wall, or history of sudden cardiac death in the patient or their family. Other factors are also mentioned in the second slide in the bottom. Now, when my talk started, the topic was when to intervene. These are the possible 4 sequelae of hypertrophic cardiomyopathy. I mentioned sudden cardiac death, progressive heart failure, dyspnea, advanced heart failure to end-stage disease, non-obstructive, while the progressive heart failure was obstructive disease, and atrial fibrillation leading to stroke. Let me mention about the echocardiographic findings so that I can elaborate on these 4 circles that you see, and that will cover my subject, and probably I'll end there, even though I have other slides to see, but I don't want to exceed my time at this late hour. Sudden death, we give ICD, and the rate of benefit is profound in these patients. Progressive heart failure, which is obstructive variety, as you see, the echocardiographic finding may reflect the SAM, systolic anti-emotion, ASH, asymmetrical septal hypertrophy, or obstruction, or heart failure. For the progressive heart failure, we use negative inotropes because it is a condition of profound myocardial contractility. And that contractility is circumferential rather than longitudinal, which in a normal person like you and me, it should be. So we use drugs such as beta blocker, diltiazem, verapamil, or disopyramide. We use for septal hypertrophy alcoholic septal ablation. For posterior wall thickness hypertrophy greater than 30, use myectomy, and they are pretty beneficial. The mortality of myectomy is only 0.4, while septal ablation 1.6, and has other attendant morbidity complications. For advanced stage, we give a transplant, and we know how to treat the AFib and congestive and the stroke. 19 genes identified on sarcomeres. First identification in 1990. More than 435 mutations have been noted. And since the disease is not that much fervent and frequent, it's hard to count so much on the mutations. Symptoms I have already mentioned, signs I have already mentioned, they would be either of the congestive heart failure or stroke or whatever. This slide I'm showing you only to show you the phenotypic heterogeneity which attends upon the gene abnormality and mutations. You see the dots where you see it, I mentioned already and I'm repeating it, hypertrophy, obstruction, contractility and onset in childhood or late. As you see, the hypertrophy may be anywhere, minimal, severe, intraventricular septum, apex or mid portion of the heart, obstruction likewise left side or right side. Therefore, the echocardiogram would be of great significance here. The genetic testing for hypertrophic cardiomyopathy, this is the latest at this point so far that we know. Comprehensive or targeted testing, especially of MYBPC3, I call it MyBPC3, and these are all the genes that you have there, many of them. They should be done mandatorily in a patient who had a syncope and has established diagnosis of hypertrophic congestive myopathy. The second slide that I show here, genetics for hypertrophic cardiomyopathy, other genetic causes of unexplained cardiac hypertrophy is recommended in patients with atypical clinical presentation. In other words, that becomes a matter of judgment. And then finally, the third one, you have mutation-specific genetic testing is recommended for family members and other. If there is an established diagnosis of hypertrophic cardiomyopathy and sudden cardiac death, all the family members should be tested for it. The worst of these gene mutations are beta-myosin, heavy chain, and look at the bottom, higher incidence of sudden death. While in this one, binding protein C, mild hypertrophy, less chance of sudden cardiac death. Having said that, this is a sudden cardiac death, EKG. Now, in summary, therefore, what I have talked to you about so far is the definition that normally one should employ, the clinical presentation, the signs and symptoms of that clinical presentation, and the treatment, whether it's a surgical treatment, medical treatment, or the targeted gene treatment. However, the yield of the genetic testing is only 35%. The cost is about $5,000 to $6,000. And the combination permutations, the mutations are so infrequent that even though you detect the same mutations, it may not reflect in the same phenotypic appearance. Therefore, you cannot just count on genetic testing alone. The cost is enormous. What test should be carried out, and that's my final statement. A, electrocardiogram, very cheap. B, definite echocardiogram, because that is the diagnosis. Then LGE, late gadolinium enhancement on cardiac MRI. Cardiac stress test with challenge, echocardiogram or with other agents. And CT scan, the Holter monitor, if there's any incidence of sudden cardiac death. And if you do all these things, you unravel the diagnosis of congestive heart failure in the patient. Now, finally, once you have got the diagnosis of HCM in a patient, it is mandatory to get the family involved. In summary, therefore, the diagnosis and the interventions should include history, and history. History of present illness, history of past illness, syncope or not, explained or otherwise, and family history. Very important, family history, family history, family history. And then the testing. And the testing should start with the least expensive tests, so that for a country like India, even for America, they don't do genetic testing on everybody, because genetic testing has two drawbacks. A, every lab doesn't have the same result, and B, the interpretation of those results, and C, a lower yield. I think that way I can show you a few slides without talking, and you can see it. This is M mode showing Sam and Ash, gradient. Video is not working, so that's over. Thank you very much.
Dr. Seth, that's an elegant, that's an elegant presentation, very well done. Very quickly, this hour is late, very quickly in 30 seconds, what are the specific indications for defibrillators in hypertrophic cardiomyopathy? Specific, like less than 30-second answer. Indications for defibrillators, ICD.
Any patient who had an incident of syncope and is young. I'm not talking about the syncope due to age 95 with the triple vessel coronary artery disease. So young patient, and if this patient has, as I told you, that slide, should I go back to that slide or you'll believe me? Okay. If the left ventricular hypertrophy in the posterior wall is greater than 30, if there's an unexplained syncope, if the LG is greater than 15, that slide is not there. I wanted to show that slide on LG, that would have been good, but anyway. And if the family history is there, so you should do it. Also, if there is a history of arrhythmia and you document all that in a young 25-year-old patient, or person, doesn't have to be patient. Person can be standing just on the train station waiting for the train to come, and he may collapse there. It has happened, in fact, last year or this year at American College of Cardiology. A case was presented from Harvard for this situation. So you have to insert ICD because that's the life-saving measure. And one thing that you didn't ask, but I'll elaborate it, that if it is a primary prevention, the discharge is about 4% per year, but if it is a secondary, there's about 13% per year, especially if it's an older patient. So these false discharges are probably a problem, but false discharge is better than the true sudden cardiac death.
Okay.
See,
Fine.
since this is a preventive cardiology conference, all the chairpersons are from abroad, speaker is from abroad. The practical difficulty in our country is, I hope my friends will vouch for me, a patient comes in the clinic, a boy comes, young boy comes for the examination for the fitness for games. And the form is that I have examined the patient and he is fit for this. This is what happens here. You see, as a good clinician, good history as he told, and then for finding out this cardiomyopathy, at least we have to do an ECG and echocardiogram. This is not done here. I think this conference should give a recommendation that for fitness for the medical examination for games for young boys, this examination should be done, and the government should accept it and bear for, any organization should bear for this repeat. I don't know what is happening in USA about such, but there must be more meticulous in examining, making fitness for this.
We don't have. I was involved in examining the police people for the state of Missouri 5 times in a row. No requirement there too. But I do it anyway. I don't want to get sued.
See, something happens if that boy, later on your medical examinations you have not done anything, then you are likely to be called in the court of law.
Exactly.
I hope you agree with me.
I agree with you completely.
Fine.
Yes.
Thank you. Thank you very much, Dr. Seth.